just means the imaging sequence of the liver and the biliary tree, which is the internal hepatic plumbing. Okay. So we do two different kinds of liver imaging. Actually, we do a couple, but two are this is the most common. The second most common is called liver and spleen imaging. So we give two different drugs for that. So liver and spleen imaging is, we give sulfur colloid for that one. And it is the drug is actually metabolized by phagocytosis. It basically takes all in the radiculoendothelial cells to show us the structure of the liver, okay? But hepatobiliary imaging is more geared toward the plumbing of the liver, okay? So that's what we're looking at. So when you're doing hepatobiliary imaging, you are going to, when you inject, you're going to inject an IDA compound of a dose range, and you're going to see liver immediately within, a minute or so. By the time you get the patient out of the chair on the bed, liver is there. And then you're going to see that the liver, this hepatocytes in the liver are actually going to process this IDA compound, and it's going to follow the same process that bile does. So it's going to be cleared from the different lobes of the liver through the intrahepatic ducts, brought down through the hepatic duct, into the cystic duct, into the gallbladder, and then when the gallbladder is full, the gallbladder will release it back out through the cystic duct, and out into the common bile duct, and then out into the intestine. So those three things you're going to see on a HIDA scan, or hepatobiliary imaging, right? Liver first, biliary duct second, gallbladder third, intestinal activity. Okay, that's your normal progression of that. So, all that. So, there are two types of cells in the liver, and I just told you what they both were. Was anybody listening?
Kepler cell? Cells.
Right, endothelium. Radiculoendothelial cells, or RE cells, or Kupfer, however you want to say them, they're all the same thing, and hepatocytes, right? So you will hear them called Kupfer cells, RE cells, or reticuloendothelial cells. Usually, RE is what I usually end up calling them, just because it's easier to say RE than it is to say Kupfer and reticuloendothelial. Okay. So anatomy and physiology of those hepatocytes, right? So the hepatobiliary system is made up of all parenchymal cells, okay? It comprises the majority of the liver's mass. Okay. Its big job is to secrete bile to aid in the digestion of the foods that we eat. And bile is fluid that it contains bile salts, cholesterol, bile pigments, and water. Okay. So anyone that has had the stomach flu after they've thrown up everything they could possibly throw up knows exactly what bile looks like. Okay. It's that cholesterol, that bile pigment, and water, and the salts. The bile salts is what makes it bitter. The cholesterol and the pigments are what make it that nasty, greeny, brown color. Okay, and water is what makes it fluid. Okay. So what the hepatocytes do within the liver are they localize these IDA or IDA radiopharmaceuticals. So like we just talked about, this little diagram of the liver, okay? Liver, gallbladder, pancreas, and the duodenum, which is the duodenal sweep, and the stomach. So the hepatocytes are going to take in this agent, right? Or they're going to start to create bile, which they do all the time, all day, right? That's what they do. So from the hepatocytes, the bile is going to go either to the right or the left hepatic duct to be drained, into the common hepatic duct, into the cystic duct, into the gallbladder, back out of the cystic duct, into the CBD or the common bile duct, through the sphincter of body, and down to the duodenum, which is just the beginning of the intestine. Okay? ready for me to go, that's a month of flight. Are we good? So, a normal height scan at 60 minutes looks like this, right? So here's your liver. Looks like an Andes cap, right from the side. Here is your intrahepatic ducts, gallbladder, common bile duct, and duodenum. This is just bowel activity, okay?
Are the images always blurry?
Yup. That is why every other imaging department calls it unclear medicine instead of nuclear. Okay, remember your imaging random decay, right? So,
Yeah, does it have those bigger for the screen?
nope. Nope, that's pretty much what they look like. Okay? It's a little clearer on my screen, but not a whole lot. That's typically what it will look like. Okay? When it starts, your entire liver is this color, this black, this as dark as it is, right? Because the hepatocytes are just taking up the activity, right? They haven't started to process that bile and process that radioactivity. So that's why your liver now at 1 hour looks patchy, right? Because now it is draining all of this Cholotec, dicefenin, mebrafenin, whatever you decide to use of your IDA agent, right? It's processed it out of the liver. So now your liver looks a little patchy. That's normal. That's what you want your HIDA scan to look like. Okay? That's what they should look like, because it means the liver's doing its job, the hepatocytes are doing their job, they're processing that IDA agent and carrying it through the biliary tree. And that's what we want it to do. Bile is carried from the hepatocytes into the biliary tree. So we know what bile is made out of, right? But what is it a product of? So it is a product of erythrocyte breakdown, okay, and hepatic metabolism. So, that being said, one of the #1 labs that you're gonna look at, so there's 2 schools of thought for nuclear medicine, and this is for every exam that we do, right? There are 2 types of physicians, okay? You've got nuclear physicians they're all radiologists, right? But you've got specialty trained nuclear medicine physicians. Those specialty trained nuclear medicine physicians are gonna go, they're gonna research their own stuff. They're gonna wanna know X, Y, Z. Okay, they don't need to be spoon-fed, they don't need to be handled, they don't need to be explained it to, right? Because they are, they're nuke med docs, okay? A lot of times they work at big hospitals. When you're at HUP, when you're at Pennsylvania, you are gonna have fellowship-trained nuclear medicine physicians on site there. And they're gonna do something called protocol. They're gonna protocol your patient. Okay, so when they protocol your patient, they are going to go into the patient's medical record and they are going to look at their ultrasound and they are going to look at their other imaging studies and they're going to look at their labs and they're going to say, okay, I want you to give this much activity and take a picture this way, this way, this way, and this way, and then bring it back to me when you're done. Okay. Then there's every other radiologist on the planet, okay, who it is now your job to look at the ultrasound report, to pull the patient's labs, okay, and to get a picture of the history for your physician, right? Because they can read nuclear medicine, but they've got 75,000 other things they have to read. They don't have 15 residents and 35 doctors, right? So you're at a smaller institution, they're busier. So they need to be, I don't wanna say coddled, but represented. The cases are presented to them. You're gonna call the physician and say, hey, I have a HIDA scan on patient 332, this is her labs, this is what her ultrasound showed, blah, blah, blah. Take a look at her pictures, let me know what you want me to do, kind of. So those are the two kind of school of thoughts. So, knowing that bile is a production of erythrocyte breakdown and hepatic metabolism, what do you think happens to a patient's liver function tests when their liver's not functioning well? Correct. Their labs are going to be elevated, right? Which means your labs are going to be elevated, which means your hepatic metabolism is going to be decreased, right? Which means you're going to have more bile in the blood, right? Your bilirubin is a key component inside that bile, and your bilirubin is going to be higher, right? So when your bilirubin is higher, your nuclear medicine study is going to do exactly what's inside. You are going to have a funky looking picture with a liver, and it's not going to do a whole lot, right? So it's important to kind of remember, we are physiological imagers. We only see anatomy because of the physiology of the organ, and this is true for every single organ that we see in general nuclear medicine, okay? So bile's whole job, okay, is to emulsify the fats in the foods that we eat, stimulate peristalsis, okay, and enhance absorption of fatty acids. Bless you.
Bless you.
So, going back to the patient's history, now, back to that, why are we taking a patient's history? So we're gonna look at their labs to see what their bilirubin is, because we wanna see what their lab work looks like. How are their hepatocytes functioning, okay? Number two, your patient's gonna come in and they're gonna say, my stomach hurts. So then your question is going to be, does it matter what you eat, right? If the answer is, it's fine when I eat green beans, but when I eat McDonald's, I have abdominal pain, right? This is why. Because the gallbladder squeezes harder when you eat McDonald's, because its job is to help emulsify fat. It knows you've got bile stored in there, so it squeezes really hard to push out the bile to help digest the fats in the food that you just ate, right? So, you've got a couple things that we look at for a HIDA scan. The two main reasons that you do a HIDA scan are to rule out cholecystitis. That's number one, okay? Cholecystitis is an inflammation of the gallbladder. You can either have acute cholecystitis or you can have chronic cholecystitis. So in acute cholecystitis, the gallbladder is just giving up the ghost. It's not going to do anything. Okay? It is contracted, it has stayed that way, and it is going nowhere. It doesn't matter what you do, it does not relax, it's going to stay either contracted or it is so inflamed and swollen that it cannot function. Chronic cholecystitis is a partial blockage or inflammation, okay, of that gallbladder wall, and that can be for a lot of reasons, right? You can have chronic cholecystitis just from poor diet, right? You've got some kind of infection, you have gallstones, but all of these patients, whether you have acute or chronic cholecystitis, they almost all have right upper quadrant pain, nausea, and vomiting, almost all of them, vomiting and nausea and pain are worse with food. Okay? So now, what does it look like when you have, on your study, when you have chronic cholecystitis versus acute cholecystitis? So if you have acute cholecystitis, the gallbladder is never going to show up. Okay? Because it is swollen and it is not functioning. We're doing, no one calls me. Everyone knows I teach, right? Everybody knows in the free world. That's 4 people have called me, both my kids included. Like they don't know where I'm at, right? Sorry. So when you have acute cholecystitis, the gallbladder never shows up, right? Because it's so inflamed. It's an acute process. It's an onset right now, and it's very inflamed and it's not working. So what that looks like on our study is the liver is functioning fine. So your hepatocytes are still processing the bile, right? Taking it into your intrahepatobiliary ducts, and it goes down into the hepatic duct, and it can't go into the cystic duct because the gallbladder is very swollen or it's obstructed. Bless. So it just goes, okay, and it goes right out the common bile duct and goes right into the intestines because it can't get into the gallbladder to be stored. Okay? So, in chronic cholecystitis, the gallbladder will show up eventually, right? It'll show up eventually. So when you are doing a HIDA scan, a normal HIDA scan is 1 hour. So in 1 hour, you should see liver, gallbladder, and duodenal sweep in 1 hour. Okay? If you don't, these are general rules. You wait 30 minutes, take another picture, wait another 30 minutes, take another picture, right? So at that 2-hour mark post-injection, now you know that the gallbladder is not, something is up with the gallbladder, because up to 2 hours is normal variant. If your patient hasn't eaten in more than 24 hours, sometimes the gallbladder has delayed visualization, sometimes if they're on certain medications, it has delayed visualization, right? So up to 2 hours is still considered a normal HIDA, like a normal HIDA scan. So you're gonna bring this patient back down at 4 hours. Now when I say 4 hours, it means 4 hours after the time that you injected them. And basically what you wanna see is, does the gallbladder show up or not? Because that is gonna tell the radiologist, is this acute or is this chronic? If it's acute, the gallbladder does not show up. If it's chronic, the gallbladder is there. Either way, we're done as med techs at 4 hours. We're done. Okay? So you do get patients that have these lovely little things called cholelithiasis, which is the fancy word for gallstones, right? They are stones that are in the biliary tree or in the gallbladder itself. The gallbladder looks like a little kind of a wine sack. Okay? We do not see gallstones in our studies. What we see is the effect of the gallstones on the gallbladder and the biliary tree. Okay? Ultrasound is the gold standard in imaging to rule out gallstones. Okay? Sometimes they're too small for CT to see. Okay? Ultrasound is the gold standard to see if the patient has gallstones. Okay? What you can say is, your doctor will say to you, the doctor that ordered it says, hey, my patient has gallstones, I need a hepatobiliary scan. What they're asking you is this gallstone obstructing the bile path in my patient? That's what they want to know. And depending on what shows up in the biliary tree, you can tell them where the stone is lodged. Okay? If it's lodged in the cystic duct, your gallbladder is not going to show up. Or your gallbladder is going to show up and nothing else will show up. Because it can get in, but now the patient's moved, sneezed, lifted their leg, whatever, moved it over to completely obstruct that cystic duct, and now it won't come out. So we can tell them a lot of things by that fuzzy little picture. You know, it looks like, oh my gosh, how do you, but we really can explain a lot about a patient's condition just by looking at the physiology of the organ that we're looking at, okay? And HIDA is a great example of that. So, you have a couple of things that you always have to ask your patient, okay? And things you need to find out as far as a patient preparation or an indication for the study, okay? Has your patient had a cholecystectomy? Meaning, did they get their gallbladder taken out? There's two ways to do a cholecystectomy. Most often it's done as a laparoscopic procedure. If your patient is very large or they had a gangrenous gallbladder, they won't take chances and they'll do an open cholecystectomy, which is very easy to tell because the patient's got a huge scar. Okay, so that's the removal of the gallbladder. Sometimes you can scan a patient after that for what's called a bile leak study. Patients only have bile leaks after a surgery because you are born with a functional, if you have a biliary tree, it usually does not have a leak of its own. You can be born without a biliary tree, which is called biliary atresia, which you will only scan on baby babies. Because if they don't catch it, the baby will die. They're going to liver failure. Okay. But you will commonly do HIDA scans for bile leak studies. Okay. Because again, we can acquire a dynamic image and they can watch it like a movie to see where exactly does this bile go. Does it follow the normal anatomical path of bile? And if it doesn't, that's how they know that it's a leak. You can also have patients with something called a JP, which is a Jackson-Pratt drain. There's a couple other drains, but the JPs are the ones you commonly see for these. They're little drains with little bulbs on them that hang on the patient. They want what the physicians will want to know in that instance is there radioactive bile in the drain? Right? Because if there's radioactive bile in the drain, it's indicative of a leak. Just because you have fluid in the drain, it doesn't mean it's bile, because they rinse everything out. When you have a laparoscopic procedure, there's extra fluid in there. You have abdominal fluid, saline, blood, it's kind of stuff. Okay. So then you have a condition called jaundice. Okay. So jaundice is either a function of poor liver function or severe blockage in the hepatobiliary tree. You will be able to tell that your patient has jaundice because the whites of their eyes are yellow. Their skin is yellow. And if it's really bad, their entire abdomen is bright yellow. Okay. We lovingly call them imaging big bird. We got a big bird bed forward. Okay. Because that's the way to communicate what's wrong with your patient without breaking any kind of violation. No one knows, everyone, no one's still going to be looking for big bird, okay? But they're very easy to spot, okay? And then you can have something called bile reflux. Okay? If you're looking for bile reflux, a bile reflux study is usually on smaller kids, okay? We don't normally do that on adults unless they've had a Roux-en-Y gastric bypass. So a Roux-en-Y gastric bypass is the old school gastric bypass where they reroute your entire GI tract from the stomach on around, okay? You have an old-fashioned Roux-en-Y, and sometimes you can get that bile back if they kink that common bile duct on the way out.
The entire what? I'm sorry. You said they reroute the entire what?
Digestive tract. They cut your stomach in half, they move it, they reroute your common bile duct, your cystic duct, they reroute everything over because they're taking all your stomach out. So
Do they still do that today?
they
or
change
it's
the
just
order
like-
of your plumbing.
Do they still do it today, or it's just like on patients who've had it a long time ago?
Depends on how big your patient is. Sometimes it's not safe to do it any other way.
Oh, so they do still do it on some patients?
Okay. Bile reflux cannot be controlled with medication or anything like that. It is usually a surgical problem, which requires a surgical solution. Okay. You also need a delayed view, meaning maybe a 24-hour picture or a 6-hour picture. So you also have a condition called a choledochal cyst, okay? Which is a cyst that usually grows inside the common bile duct and actually bursts and obstructs the entire biliary tree. So then we have something called biliary atresia. Biliary atresia is the congenital absence of biliary tree or a closure of the biliary tree. 99.9% of the time, it is a congenital absence of biliary tree. Okay, very rarely is it ever a closure of the biliary tree. Usually the baby is born without one. Okay, so what we do is we pre-treat, well, we don't, the nurses do. We'll pre-treat these babies with phenobarbital, okay, for 5 to 7 days to try to see if they have any biliary tree at all, to try to force if there's anything that's maybe it's just collapsed, right? So we can't see it because it's completely collapsed. To try to enhance that biliary excretion to see if we can force anything open, okay? So a biliary atresia image is 5 to 7 days with phenobarbital, inject, scan the next day. Okay, you have to do a 24-hour image. These babies are itty bitty. Itty bitty, they're brand new, fresh out of the patch. Okay. So what is the prep for this study? Okay, your patient has to be NPO 2 to 14 hours prior. Now that comes from Shapping. Typical standard is 4 to 6, right? That's your normal. Your normal is 4 to 6. 2 hours for a little kid or a baby, because they eat every 2 hours usually anyway. Okay. No narcotics or sedatives. The key to that is opioids. No opioid narcotics. Okay. What happens is they cause that little sphincter of Oddi to contract, and then it's going to stay that way. So it's either going to give you a false positive study, or if it was open, a false negative study. Okay. Usually it contracts and stays that way, so typically it's a false positive because your bowel never shows up. The reason the bowel never shows up is because you have now done a pharmacological obstruction. Okay. If you give a patient atropine or the patient is on atropine, it prolongs the gallbladder contraction response, meaning typically when you give cholecystokinin or Kinavac or Syncolide, any of these agents that basically mimic cholecystokinin that you give in practice, cholecystokinin is a hormone in your body that your body naturally gives off when you eat something that tells the gallbladder to contract, okay? Atropine, patients that are on atropine have a prolonged contraction response. So say you gave me, right, I had a height scan, you give me, I'm good at 1 hour. Usually within 30 minutes, my gallbladder is already contracted and is starting to refill. But if your patient is on atropine for some reason, it is not going to happen in that typical normal fashion. So you're gonna have to image those patients for ejection fraction longer. And that is a call the radiologist, when do you want me to start or stop imaging? Because any radiologist will have to look and see how long the patient's been on atropine, because that will change because it builds up in the system, right? And phenobarbital is what we give the babies to enhance that hepatobiliary function. Very rarely do you ever have anyone give an adult phenobarbital for a scan. It just doesn't happen. Okay, but just know that is an end. So your patient's history. When you get this exam, you're going to say, what is the surgical history of this patient? Okay? Have they had their gallbladder out? Okay. What is their bilirubin level in their liver function test? So if it's more than 20 milligrams per deciliter, you're going to give a higher dose to the patient. Okay. The other thing you also can look up is just total bilirubin. Total bilirubin, the top normal is 1.3 in most cases, most labs. So if your patient's T-bili, what they call it, total bilirubin is more than 1.3, you are going to give a higher dose. That dose can be up to 10 millicuries. We're going to go into what doses are and stuff in just a couple minutes. Okay. What kind of medications do these patients have to be either on or off of? Okay. So if you're looking for biliary atresia, your baby needs to be on phenobarbital to enhance that hepatobiliary function. If it's atropine and you're looking for an ejection fraction or just a regular imaging study, you're going to need to know that you're going to have a prolonged response. But your patient cannot be on any narcotics, morphine, Demerol, anything like that, or you will get a false positive study. Or false negative, false positive is more common. Okay. Nothing to eat or drink for at least 4 hours, 4 to 6 hours. Because food causes the gallbladder to contract, and if the gallbladder is contracted, it's not going to store the bile that you're tagging to be able to see. Okay. If your patient has been fasting more than 24 to 48 hours, okay, you are going to have a delayed visualization of the gallbladder anyway. Some institutions will give the patient morphine, wait an hour, and then start the HIDA scan. Okay? Because that morphine, for the same reason that you don't want to give it when you're imaging, because it causes the gallbladder to contract, is the same reason you give it prior, because you want the gallbladder to contract, so it can contract, relax, and start to fill. Okay?
Says you give them morphine if they've been fasting more than 24 hours?
Depends on what your protocol is.
Okay.
Yep, not everyone does that. It depends on your authorized user, but it can be done. Some locations routinely do it, it's just part of their protocol. Okay. As long as you have to make sure that they're not allergic to it, right, obviously. Okay. So what are the contraindications for a study like this? Your patient comes in and they got McDonald's on the way, they're canceled. Okay. They ate, they're done. If they've been fasting longer than 24 to 48 hours, then you need, that's a question for your radiologist. What do you want me to do? Okay. Make sure that they're not pregnant or breastfeeding. Okay, and if they haven't had any recent contrast studies, not for the reason that you think them. Okay. Contrast is iodinated and it's very thick. So iodinated contrast is cleared through the kidneys and the bladder, but if they had oral contrast, it's cleared through the stomach and the intestines. And it will absorb your gamma rays and look like you have abnormalities on your study when you do not. Okay, so no recent contrast studies. And if you're administering CCK, you have to know that the patient has no CBD obstruction, common bile duct obstruction. How do you know that? Because you're waiting for at least 1 hour to be able to see liver, gallbladder, and duodenal sweep or bowel before you administer CCK on any patient. Okay. The jury is out on if your patient has stones, if you give them Kinevac, CCK, whatever, cholecystokinin, Syncoline, whatever you want to call it. Okay. Some physicians will not allow you to administer this Kinevac to patients if they have gallstones. The theory behind that is if the stone is small enough, you could force the gallbladder to contract and push the stone out of the cystic duct and into the pancreatic duct and cause pancreatitis. The other half of the radiologists say that's crap, that doesn't happen. So it depends on what school of doctor you are, whether you're going to give CCK to patients that have stones or that don't have stones, and up to the radiologist. Okay. I will tell you, if you do give CCK to a patient that has stones, they will be hurting kids. Okay, so just be prepared for that. They're gonna belly ache.
What about patients that are like on long-term, like benzos or narcotics? They can't have it for more than 48 hours, like when it already builds up in their system, so.
So it's opiates,
Okay,
any kind of an opiate.
so if they're on it like long-term, would that affect? this?
Most patients are not on long-term opiates, they cannot have them, period, they just can't. So they either have to go off their meds, or they don't get the test. That's it. Okay. The only, grievance to that, or I shouldn't say grievance, the only caveat to that is fentanyl. If your patient's in the hospital and they're on fentanyl, fentanyl's metabolic half-life is like 13 seconds. So by the time they shut off that fentanyl drip, by the time they get downstairs, that fentanyl's gone.
So if it's like a chronic pain patient, they would have to pick a different study for them, it wouldn't
Yep.
work? Okay.
Yep. Only if they're on opiate pain medications.
Right.
If they're on long-term Toradol, doesn't matter, Toradol's not an opiate.
Okay.
So there are a lot of pain management drugs that are not opiates. Yeah. So again, when you get your patient, you're gonna ask them, have you had your gallbladder removed? You're gonna check their bilirubin and their liver function tests, okay? You're gonna check their medications. What medications are they on? The only medications we care about for a HIDA are opiate pain medicines. We don't care about anything else. Okay. If the patient has been fasting for more than 24 to 48 hours, you're gonna reach out to your radiologist to see what exactly they want you to do. Now to the nitty-gritty. Radiopharmaceuticals. Your radiopharmaceutical range, according to Shackett. Now, the reason that we put according to Shackett is because the package insert of a drug, which we will go into ad nauseum next semester, okay, is the manufacturer's recommended dose range, okay? Those doses are based off of a standard man. Standard man is 170 pounds, okay? So your normal dose for a HIDA scan is gonna be 3 to 5 millicuries. That's your normal dose, okay? In my career, I've never given anybody more than 10 millicuries of Colotec. Mefenamic, diclofenac, okay? That is my authorized user's max dose to give, okay? But Shackett, when he does his book, he does a nationwide and says, what is everyone giving? And that's how you get the 3 to 15, okay? So that's why you have such a big range. The reason you have such a big range for this drug is because it is dependent on liver function. Okay. So if you have a patient with poor liver function and say they're 10, right? you're still, even though their liver function is poor, you're not gonna give them 10 millicuries of an IDA compound, because they're a little kid, right? So you're gonna use your pediatric dose calculation, which is by weight most of the time, or body surface area, which again, we'll get into next semester. And then you call your radiologist and say, this is their bilirubin, this is the prescribed dose, what am I giving? What do you want me to give? Okay. So they're called IDA drugs, IDA compounds, but they're all derivatives of this word here that I can never say and have not been able to say for 30 years. Imidodiactic. It's an acid. Okay. But the most common one that you are going to see is called mebrafenin. Mebrafenin is the most common agent given for hepatobiliary scintigraphy. Okay. Mebrafenin is commercially called Colitec. Just like every drug on the market, it's got a brand name and a chemical name, right? Mebrafenin is Colitec. That's what the most common one. However, there is a lidofenin and a dicefenin. They're different manufacturers. They're a little bit different on the acid, on the little amino acid chain that they use, but they all do the exact same thing. They function the exact same way. Okay. So it is called a HIDA agent, a DISIDA agent, or any kind of IDA compound. Okay, IDA because it's amino diactic acid, right? So it's IDA. That's why they call them IDA compounds. Okay? Depending on how old your doctor is that you're working with, sometimes they'll say they want a DISIDA scan, they want a HIDA scan, they want a gallbladder study. Like, there's just a million names that they call it. But the most common is HIDA. Back in the day, we used something called rose bengal, and it was tagged to iodine 131, and it was a cholesterol derivative that was tagged to iodine 131 that would show you the biliary tree. The reason we don't do that anymore is because A, rose bengal is a metal, okay, your patient, if they have to do it too many times, they had metal poisoning, and I-131 is a high energy radioisotope, and it gives the patient a lot of exposure. A lot of exposure with no benefit, right? So we don't use those anymore. But it is out there. I mean, it's not out there anymore, but you may see it in breathing if you're breathing something old. Your method of localization. This is going to be your favorite thing that we're going to do next semester. All your methods of localization. Method of localization just basically means, how does this get where it's supposed to go, right? So all hepatobiliary agents, all of those IDA compounds are taken up by the hepatocytes, and they follow that path of bile. Okay. So it is penocytosis, which happens at the cellular level, that draws that process in, that draws it into the hepatocyte, okay? And it's taken from that by active transport to the gallbladder. Okay? Penocytosis is how the drug gets into the hepatocellular, through the hepatocellular wall and into the actual hepatocyte. And then it's an active transport process into the gallbladder itself. So there is a chart in Metler on page 229 of all the pharmacologic agents that you use for a HIDA scan, right? Morphine sulfate is your morphine that we were talking about, TCK and phenobarbital. So morphine is 0.04 milligrams per kilograms of patient weight. It is always diluted into 5 to 10 ml and given as a slow push to the patient. Okay? You can give it if the patient's been fasting too long, Or if you have non-visualization of the gallbladder, you can use morphine to determine if it's acute versus chronic cholecystitis. Okay, 0.04 milligrams per kilogram of patient weight, diluted into 5 to 10 ml with a slow push. Now, CCK can be given a couple of different ways. CCK is cholecystokinin, which is what I said is the natural hormone that your body creates and sends to the gallbladder to cause your gallbladder to contract whenever you eat, right? We're just piggybacking on that function when we're looking for gallbladder function, okay? So you can either give it IV push, but very slow, or you can IV drip it, which means put it through an IV pump and let it drip. If you are doing it to stimulate the gallbladder when the patient's been fasting more than 24 hours, instead of morphine, okay, it is always a drip. Okay. So if you are pre-treating with CCK, it is always a drip. If you are imaging with CCK, it can be done either way. It depends on your hospital's protocol. Where I work, we IV push, and we have always IV pushed it. Just the way that we do, you just have to make sure you go very slow. If you bolus CCK into a patient, they will 100% throw up on you. Don't ever do that. 100% will throw up on you, even if there's nothing wrong with their gallbladder. Okay? We call that a positive PF.
Is that like an immediate reaction, or it takes time?
No, pretty much while you're standing there. Like you go and you IV push and you go to flush it, you're wearing it. It's quick. Okay? So never IV push CCK. It's not nice.
So how slow do you go?
So we infuse ours, we dilute ours to 3 ml, and we do 1 ml a minute. Okay. So it's an IV push over 3 minutes. Okay. However, if you IV drip it during your study, that is more of a natural occurrence. Your body doesn't just all of a sudden push it through. Like it's a natural, it's a slow process when your body releases its own CCK. So the IV drip for an ejection fraction, for that stimulation of the gallbladder, is a little more of a natural process. Okay, and it just depends on where you work, what the physician wants you to do. Okay, so CCK. If it's a pre-treat, it's always a drip, okay? If it's diagnostic CCK, it's push or drip. But the dose is the same no matter what. 0.02 micrograms per kilogram per body weight. Okay? And phenobarbital. Phenobarbital for the babies. It's oral, obviously, because they're babies. 5 milligrams per kilogram per day for 3 to 5 days. Sometimes up to 7, typically 3 to 5. Okay. So morphine and CCK can both be given to pre-treat when patients are fasting for too long of a period of time. CCK and morphine. Morphine is given to distinguish between acute and chronic cholecystitis, whereas CCK is given to calculate the function of the gallbladder itself. Okay. And phenobarbital does what? Kids, but what does it do? Why are you giving it to the kids? You're trying to
You can visualize if they have
increase their hepatocellular excretion, right? That's why we're doing those.
You said morphine's given to calculate the function of the gallbladder.
No. CCK is given.
To calculate the function of the blood?
Correct.
Okay.
Morphine is only to distinguish, it's either a pre-treat or if it's an acute versus chronic cholecystitis. Can we make the gallbladder show up? CCK is what you give when you want to see what the function of the gallbladder is. Okay? Now, what is the imaging criteria for these patients? So your imaging should begin either immediately, but within 5 minutes of giving the patient the injection. Okay. Most of the time, you are going to either have your patient already under the camera and give them the injection. By the time you go assay your dose and come back, it's time to hit the start button. Or you're gonna inject your patient in the injection chair, and your colleague who's in the scan room is gonna walk over and go back to them and then put them on the table. Okay? But you can do immediate to 5 minutes post, but you shouldn't start any later than 5 minutes post. Okay? You are going to lay the patient on their back. The liver is gonna be in the right upper part of the screen, and you wanna make sure that all of your liver is visible. Oh my Lord. Visible. I need more caffeine, I'm sorry. Visible. Okay. Now, sequential images every 5 to 15 minutes are required for 1 hour, and that is one way to do a HIDA scan. Okay? If you're doing static images, do you see it says sequential, not serial? What's the difference between serial imaging and sequential imaging?
Serially put together as like one whole study?
Serial is a dynamic. It's one after another, after another, after another, after another. Sequential just means over a period of time, right? So sequential images are static images that are acquired every 5 to 15 minutes for 1 hour. Your typical is immediate, 5, 10, 15, 30, 45, 60. That is your typical static time that you're acquiring these images, right? Immediate, 5, 10, 15, 30, 45, and 60. Some places will throw in a 20-minute picture for good measure, okay? Or you can take serial images, which is a dynamic study that acquires a 1-minute picture every 1 minute for 60 minutes. Okay. When you are done, either way, and you see gallbladder, it is always best practice to do a right lateral image and a left anterior oblique image. Okay, that is best practice. Right lateral image is going to pull the gallbladder forward and it will separate it from the bowel. Your left anterior oblique image will pull the gallbladder off of the common bile duct. If you have a dilated common bile duct, it will rotate it off so that you can separate the common bile duct from the gallbladder activity.
And it's left lateral.
Right lateral. Liver's on the right, so you want a right lateral. It is very easy to tell if your liver is cut off in any picture that you see because your liver is an Andes cap, right? And it's curved. If you have any flat spots, slide the patient down. You're cutting the top off. Okay? So, inject. Start imaging between immediately and 5 minutes post. You're either going to image sequentially every 5 minutes to 15 minutes for an hour, or serially, 60 seconds per frame for 1 hour. So 1 minute a frame every minute for 1 hour. Okay. When you're done, if you see everything, so when I say see everything, what should you see on a HIDA at the end of an hour?
Gallbladder.
Liver
Gallbladder.
and,
And the dividend.
yep, and bowel. Liver,
Bowel.
gallbladder, bowel. When you see all 3 of those things, you're gonna do your right lateral to prove that it's gallbladder, okay? And your oblique,
Separation.
and then you're done.
Okay.
Tell the patient, he's out, right? Your collimator, everyone's favorite, is gonna be a leap or a lure, okay? So low energy all-purpose or low energy high resolution collimator on a large field of view. If you use a small field of view camera, you are gonna cut the patient's liver off unless it's a baby. Okay, the liver is a pretty big organ. Okay. If you're going to do a flow study, so a flow study is almost every flow study that you do, no matter what it is that you're flowing, so to speak, it's 2 seconds a frame for 60 frames, and then a blood pool. Okay. Most places do not flow HIDA scans. They start immediately or within 5 minutes. Okay. However, if someone says to you, can you flow a HIDA scan? The answer is yes. You can flow almost anything. Okay. So if you do a static study, you always do it for preset counts. Static HIDAs are done for counts. 500,000 to 1 million. Sweet spots, usually 5 to 750. So you're gonna set up your camera at 500K to 750K, right? Which means 1,000. Okay. Or a preset time of 90 to 300 seconds per image. Most locations will do preset counts. In the event that you have to do a delayed image, okay? The reason they do counts is because counts to counts are apples to apples. So if you do a delayed image, however you acquire the study has to be how you acquire the delay, okay? So if you do a 90-second picture, which is like, what, 1.5 minutes, right? When that patient is just injected, you're gonna get a beautiful picture, but you have a high count rate, right? You've got high saturation in the hepatocellular structures, so you're gonna get a good picture. If your patient comes back at 4 hours and you take a 90-second picture, your picture's gonna look like, what the heck is this, right? So most places will do 300 seconds an image, which is 5 minutes, okay, or 500K. So 5 minutes or 500K is sort of the rule of thumb, okay? But the range is 500 to 1 million and 90 seconds to 300 seconds an image for static imaging. And you can do that, any combination of images over a 1 hour period, but it has to be 1 hour.
Is static, like what is typically done, like the static images?
Depends on your workflow and your schedule. So where I work, they're typically done dynamically, okay? However, if I have 5 HIDAs, they're all getting done static because I can on the bed, off the bed, on the bed, off the bed, on the bed, off the bed. Everybody's 5 minutes done. By the time they're done, it's been 5 minutes and I'm doing this one, this one, this one, this one, this one, right? So you can do them either way and it really just depends. Depends on what your hospital protocol is, and really how your schedule flows. So if your protocol is to do everybody dynamically, but you have 1 million patients, you just, when you call your radiologist, you go, hey, patient flow, I couldn't hold the camera up for an hour, so all the highs are static today. They go, okay, I don't care. Okay. When you do multiple patients in a row that are static acquisitions, it's very important to make sure that your timing is labeled correctly. Because you may not get every single person at immediate 5, 10, 15, 30, 45, 60, right? It may be 55 and 35, right? But you wanna make sure that you know that, because if you need to do a delayed picture, you wanna make sure you have your timing correct so everything is labeled properly. Okay. But in general, static, immediate, 5, 10, 15, 30, 45, 60. That's your typical. Okay. Always a leap or a Lear, always a large field of view camera. Okay. Either statics or dynamics. Except if it's a bio-leak study. If it is a bio-leak study, it is always preferred to do a dynamic study on a bio-leak. You can do a bio-leak study statically, but it's very difficult for the radiologist to read because they can't follow the bio path. Makes it a little harder. Okay. So speaking of cutting off the liver, here we go, right here. Boop. Yep, their liver's cut off. But this is a normal hide scan. This was acquired dynamically. Okay. So you can see in the first image, I can tell you that the first image was summed to be later than 5 minutes. And I can tell you that because you already have gallbladder. And it takes more than 5 minutes to get a gallbladder. Okay. So normally when you acquire a dynamic study, you start it immediately and then you sum those images, you compile them. So instead of making them 60 seconds a frame, you sum them to be 3 minutes, we do every 5 minutes, right? So it will be like 5, 10, 15, 20, 25, 30, 35, 40, 45, 50, 55, 60. So you'd only have that many frames, these will be done. Okay. But you can see you've got liver, and as it starts to clear, you can see gallbladder. As gallbladder starts to empty, here's your common bile duct, and it gets down, and here's your duodenum starts here, and it collects in the duodenum as it goes by, right? So here's your intrahepatic ducts, gallbladder. If you have a patient that you think that it might be gallbladder and you're not sure if it is gallbladder or not, you're not going to send a patient to CT. You are going to do a lateral or an oblique, okay? Because you want to see if you can make that gallbladder move. If the gallbladder stays in the same position when you turn the camera, it's probably a dilated duct and not the gallbladder, because the gallbladder is another organ and it will move when you take angled pictures. Okay.
If it stays in the same spot, it's probably what?
It's probably a dilated duct. Okay. So, when you get something, it's called a rim sign, okay? When you get a rim sign, it basically means that you have, this is a normal study, right? This is blown out, meaning it's way too dark on the grayscale. They should have divided it back a little bit, okay? Liver, common bile duct, gallbladder, duodenum, stomach, she means intestines, okay? Your stomach's up here, right? But if you notice here, you have the liver, which is a little different, bit of a different shape, but you have this little activity here on the outside with a hole in the middle, right? So that is typically conducive of two things. You either have a gangrenous gallbladder or you have acute cholecystitis. Okay, those are the only two times you ever are going to get a rim sign on a HIDA: acute cholecystitis and gangrenous gallbladder. Okay. More typically, when your patient has a gangrenous gallbladder, the outside of the gallbladder, the whole outside of the gallbladder wall is black, 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 and the inside is nothing in it. It looks like background. So it's a really positive, finding.
And what were the two instances? I'm sorry.
Acute cholecystitis or a gangrenous gallbladder. So, for these pharmacologic agents, when you have non-visualization of the gallbladder at 1 hour, that typically leads to a 4-hour or a 24-hour delay. Okay. If you don't want to do a delayed image, or your radiologist says we're not doing delayed images, you can administer morphine sulfate instead of taking those delayed images. Okay. You can only give morphine sulfates when you have liver activity and bowel activity, but no gallbladder. You never want to give morphine if you have liver activity and nothing else. Okay? Liver and bowel, but no gallbladder. Okay. If by 30 minutes or so you have nothing, you have no gallbladder and you have a little bit of bowel, your radiologist may say to you, we're just going to give them morphine and see what happens. That's when you're going to give the morphine and start it on a drip or give it that slow push. And then wait, and then take pictures for 30 minutes. Okay? So you're going to image for an hour anyway, pretty much. But if you know that you're worried about, you go and you're almost at 30 minutes and you don't have any gallbladder, and you can go to the radiologist and say, yo, do you want me to give morphine? They go, yeah, right? So after you give the morphine, you have to take pictures for at least 30 minutes. So this was a good, I kept this to show you the two different positions of for the gallstone scenario, okay? So you've got your right and left hepatic ducts, your common hepatic duct, and then your CBD, which is your common bile duct here. Your cystic duct is here, and your gallbladder is here, right? If your gallstone is stuck in the cystic duct, what are you gonna see on your HIDA? What is the flow of that bile if your cystic duct is obstructed?
Cold.
Liver,
Liver and pudding. Bowel.
liver and bowel, no gallbladder, okay? Reason being, the bile can't get in, it's obstructed, it can't get through, can't get up that way. Now, this is just a picture of it's like a 15, right? Here's your intrahepatobiliary ducts, gallbladder, common bile duct. See this little teeny shadow of bowel? Either way, you don't have a cystic duct obstruction because here's your common bile duct. and you have gallbladder, right? But your common bile duct is getting kind of fat, but you don't have any real bowel underneath. Okay. This is a typical non-visualization of the gallbladder, right? You've got liver, intrahepatobiliary ducts, common bile duct, duodenal sweep, bowel, 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 reflux into the stomach, bowel, 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 bowel. 4 hours, you have no liver left. So the hepatocytes have metabolized all of your radiological agent. Excuse me.
Bless you.
So you are done. You have nothing else that you can do diagnostically for this patient because they metabolized everything. It is not going to go from the bowel back up into the common bile duct and back into the gallbladder. It does not do that. Okay? What it does do when you have an obstruction is reflux from the common bile duct around the pancreatic duct and can go back up to the stomach. Because once it's in the duodenum, see, you've got duodenal activity and a lot of bowel. Here you don't have a whole lot of duodenal activity, but look how hot the stomach is. So all that activity, reflux backed up into the stomach. So that's why you have stomach on that activity. So this patient has acute or chronic cholecystitis. Acute. Okay, acute cholecystitis or a cystic duct obstruction. Okay. So, morphine. Morphine's dose is 0.04 micrograms per kilogram per pound of body weight IV. You'll hear me say it 1,000,000 times because it's important for you to remember. Okay. You're going to administer it slowly through an IV catheter, or it's going to go through a drip. If your patient is allergic to morphine, this is not an option ever. You can never give a medication to a patient that they're allergic to. Anytime you're giving a patient any kind of medication, you always have to check their medical record to make sure that you're validating their allergies. Okay. So now you've given this patient morphine, now you know what the side effects are, because now you have to watch for a reaction from this patient, okay? They can get confused, they can get a headache, they can get flushed and sweaty, okay, nausea, hurry up there, every 5 minutes they're trying to tell you to have to pee, okay? But they can also have cardiovascular reactions, right? Bradycardia or tachycardia. They can have a low respiratory rate or a high respiratory rate, okay? So it is always important to watch your patient after you administer any kind of medication, but especially morphine. Because it is a respiratory depressant. Okay, so you want to watch your patient for bradycardia, hypotension, confusion, anything like that. So why are we given this morphine sulfate anyway, right? So morphine sulfate, again, is going to be your acute versus chronic cholecystitis rule out. Okay. It causes the sphincter of Oddi to contract, which is going to force that tracer back into the biliary tree. If you give a patient morphine and you still don't have any gallbladder, your patient typically has acute cholecystitis. Okay. If you give them morphine and it shows up, it's probably chronic cholecystitis, which is the same rule as a delay. If you do a 4-hour delay and you don't have any gallbladder, it is acute. If it shows up later, it is chronic. That does not change when you give morphine. It basically just speeds it up. Okay? Gives you the answer in 90 minutes instead of 4 hours. Okay? But the results are still the same. Non-visualization of the gallbladder is acute. Visualization post 30 minutes is chronic. Okay? Last.
Thank you.
I know these slides are repetitive, and we're gonna go through another one that's repetitive, but it's just kind of like, I think it's easier to just keep saying it over and over and over and hearing it over and over and over, because the more you hear it, the better it is. Okay, you're welcome. So, here's your pre and post morphine images, right? So here you got no gallbladder, right? And you say, well, wait a minute, what is this? Right? You've got this activity here. It's bowel. Your patient's heavy. I can tell by looking at the picture, the patient is a large patient, right? So it's bowel activity over here. But look, now we give them morphine, now we've got gallbladder. So it's chronic. We can schedule your cholecystectomy, right? Versus, you have to have it done now, right? That's basically what it means for the patient, acute versus chronic cholecystitis, right? Acute cholecystitis is, this is an emergent surgery. Okay? Chronic cholecystitis is not scheduled when you feel like it.
Can you point out the gallbladder again? Is it that darker image right?
Right here.
Okay.
Yep, gallbladder. Gallbladder. The rest is bowel. Okay? All intestinal activity, all the squigglies. CCK. CCK is a hormone produced in the duodenum which stimulates gallbladder to contract when food enters the duodenum. It stimulates the pancreatic production of enzymes and increases stomach and intestinal contractions, which is why if you IV push CCK, your patient throws up. Okay? We lovingly call that a positive PF in our department, which is what we call Lexiscan when patient ate. Like, we're expecting a positive PF from this one, and the cardiologist rolls her eyes, but I'm like, maybe we're wrong. Okay. So CCK, hormone, produced in the duodenum, stimulates the gallbladder to contract when food hits that duodenum, right? Stimulates those enzyme productions in the pancreas and increases your stomach and intestinal contraction. So what I told you in the beginning was the truth. CCK is what your body releases to help you digest the fats in the food that you eat. This is the mechanism that it does that. Okay. We are going to give CCK for 3 reasons. In conjunction with a gallbladder ejection fraction study, which we're going to talk about in a minute. Okay. We're going to give it to a patient that hasn't eaten for 24 hours to stimulate the gallbladder. Okay. Now, you're going to say, why does this say Kinnevac and this says CCK? So there are multiple medications that are cholecystokinin analogs. Okay? Kinnevac, Syncolide, and CCK. Those are the 3 common ones. Syncolide and Kinnevac are pretty much the same thing. Okay? CCK, Kinnevac, Syncolide. You will see them used interchangeably. Okay? I stole this from Mrs. Mack, so that's why I didn't fix it, so I apologize. But they're the same mechanism of action. Okay? But you're going to give them, you're going to give this at a very reduced rate if you're pre-medicating them with CCK than you are if you're looking for an ejection fraction. So you're only gonna do 0.04 to 0.14 nanograms per kilogram. Yeah. Okay. You can also give this drug with the permission of the reading radiologist, okay, where the gallbladder is full, but it will not empty into the bowel. Okay. I will tell you that the only time the radiologist will allow this is if they have an ultrasound and or ultrasound, sometimes CT, but usually it's ultrasound, proving that that patient does not have gallstones. Okay? You have to have proof that the patient doesn't have a physical obstruction of that gallbladder. Okay? You can actually get away with giving it with Cardiolite if you need to get rid of the tracer out of the gallbladder, although I've never seen that done, but it's legal, I guess. We just give them water. But you can, okay? So the three reasons you're gonna give CCK, you're gonna do it to calculate an ejection fraction. You're gonna do it to pre-medicate someone who's been fasting for too long, over 24 hours, at a much reduced rate, okay? Or you can give it when the gallbladder is full and there is no bowel, only with approval from a radiologist, okay? So, Mrs. Mack has on here, fatty meal consumption may be a better alternative. So, there is the jury is out on these. So, technically, Kinavac, right, is making your body secrete the hormone to cause your gallbladder to contract because you ate, right? That's the purpose of it. If you have a CCK shortage, right, which we do, unfortunately, rather often because no one else uses it except for McMed, okay? Your physician may say, give the patient a high-fat meal, right, instead of doing a CCK. So you tell them, you go downstairs, you get them an Ensure, or you get them a milkshake, or a cheeseburger, or whatever your meal of choice is, okay? Ours for a long time was ice cream, okay? And then you go back and you do the delayed picture to see if the gallbladder empties. The reason that sometimes the doctors will tell you to give them a fatty meal instead of giving them CCK when they don't have bowel is because the patient's gonna go home and eat anyway. You're not gonna cause any harm to the patient. The patient's still gonna go home and eat, right? So it will be a long process of that CCK, that hormone released by the body itself, that we're not forcing it to happen, okay? But, so that's why it says that the fatty meal consumption is a better alternative in that aspect. And you will have some gastrointestinal doctors that will ask you, hey, my patient has gallstones, you know, I'm not sure what we're gonna do about her, but I wanna see if it empties. Can you just give her milk or something so we can see if it empties? Okay. The difference is when you're looking at an ejection fraction, the only true valid quantification of a gallbladder ejection fraction is with a drug. Kinavac, CCK, Syncolide, okay? Fatty meal will show if it empties or not, but if you quantify that number, it is not statistically valid and it cannot be reported as a solid number. So when you get if your patient is having a high scan with CCK, the radiologist will say, the patient's gallbladder ejection fraction was 37%, period, when they get CCK, okay? If you give them a fatty meal, they will say, the gallbladder visually decreased in size with an estimated ejection fraction of whatever number you give them. Okay? So that is That is the difference between the two. Okay. So now you have a stone in your common bile duct, right? So you've got your common hepatic, common bile, stone in the common bile duct. What are your pictures gonna look like? You got liver, of course. No bowel. Gallbladder and no bowel, exactly. Gallbladder and no bowel. Back up into plumbing. Okay. Which is why a lot of times the radiologist will say, give them milk, don't give them CCK if you have no bowel. Unless they have another modality that's proven that they don't have an obstruction. Okay. And sometimes that's our job to find.
So the scan would show liver and gallbladder, but no bowel.
Liver and gallbladder, but no bowel.
And then if it walks cystic stuff, it will see the liver and bowel.
Yep. It does not pass go, it does not collect 200 hours. So this is a 60-minute picture with delayed biliary to bowel transit. Would she put as consistent with chronic cholecystitis? I don't think I would, as a radiologist, feel comfortable saying that's chronic at 1 hour. I would say the patient either has I would say the patient probably has a common bile duct. Yeah. The patient could have had pictures after this, and that's how we got this report, right?
Why would you not feel comfortable saying that at 60 minutes?
Because I have gallbladder. So I would not say the patient has cholecystitis when I have gallbladder at 1 hour. That's normal. Have gallbladder at 1 hour is normal.
Where's the gallbladder, that big?
The big black thing.
Okay, yeah, that's a lot of gallbladder, so.
Exactly.
Okay.
So this is one of those times as a technologist when you go back and you look at your doctor's report and it says that and you call them up and you go, ring, ring. Can you just take a peek at this picture? Cause I'm not so sure about that. And then they usually laugh and go, yeah, so, and then they change it. They do an addendum. So that is probably not accurate. At least I would say it is not accurate. There is definitely delayed biliary transit. However, you wouldn't be done at 1 hour. You wouldn't stop imaging at 1 hour and diagnose anything, right? Okay.
How long does the scan normally take for you to be finished?
Normal is 1 hour.
Okay.
Abnormal can be 4 hours. Or 24, depending. So we have had patients that have had very markedly elevated bilirubins, 10, 12, right? They look like a big bird. So they, we give them 10 millicuries and then we scan them the next day. We don't even bother because we know we're not gonna see nothing. We inject them on the floor and we bring them down at 24 hours to see what we see. Okay. So the second part of HepatoScan imaging is to see if their gallbladder functions. So a regular hepatobiliary study is going to show you patency of the biliary tree. Okay? Acute and chronic cholecystitis and patency of the biliary tree. That's what you're going to see. So now you may have a patient that comes in and they have HepatoScan and their HepatoScan is normal. Okay? When you have a patient that has a normal HepatoScan, they may very well be normal. Everything's normal. The patient's pain is coming from something else, look someplace else. Okay? But I have been known to tell my patients that the gallbladder is the Paris Hilton of organs. Just because it looks pretty doesn't mean it works. okay? So, when you have a patient who still has symptoms, who has normal labs, and has a normal HIDA, that would say to me as a physician, I think she has biliary dyskinesia, okay? Which is a reduced gallbladder ejection rate, fraction, okay? So your patient that still has abdominal pain, still after they eat, still gets nauseous, but has a normal HIDA scan, that tells me that the patient doesn't have any junk in their gallbladder. They don't have stones, they don't have sludge, and they don't have any inflammation. But it doesn't mean that the gallbladder is squeezing appropriately when it's supposed to. That is when we do a GBEF study or a gallbladder ejection fraction study, okay? This is gonna determine how well the gallbladder contracts, which will tell the doctor when that gallbladder squeezes, what percentage of that bile is kicked out. Okay. Since CCK stimulates the gallbladder to contract, imaging is performed before, during, and after administration of CCK. Okay, that's what she means by and after. There's a couple ways to do that. So you are going to image for your first hour. So a hepatobiliary study and a hepatobiliary with ejection fraction start off as the same study. Okay? The difference is you're either going to, if your patient has everything at 30 minutes, you have a liver, gallbladder, and bowel 30 minutes, you can call the radiologist and say, hey, I have everything. Can I give the CCK? They're gonna go, yeah, okay, that might be, right? So then you start the CCK part. So CCK can be done in two different ways. It can be done dynamically or statically, okay? So if you're doing CCK statically, you're gonna take a image before you give CCK, give the CCK, and take an image 30 minutes after you gave the CCK. Okay. It either has to be for time or for counts. However you take it originally, has to be the way you take it post. Your pre-CCK image and your post-CCK image have to have the same acquisition parameters. Okay, or your math is going to be all wrong. Okay. The more common way to do it is dynamically. So regardless of how you do the HIDA, whether you do the HIDA statics or dynamic, it doesn't matter. If you're doing the CCK dynamically, you put the patient under the table, you hit the start button, you let one image collect, so you wait for 1 minute in, then you start administering the CCK, and you image for however long your protocol is. Some people image for 1 hour. Some people image for 30 minutes. It just depends. Okay? But this is the only way that you can tell the doctor a legit, reportable, this is what the patient's gallbladder ejection fraction is. It's not an estimation. This is like legit, this is what we have.
So you said the difference between the hepatobiliary and the hepatobiliary with ejection is after 60 minutes, if everything is visualized, then you start the CCK?
Yep, you give CCK at that point. Okay. But it goes back to, you have to make sure you have liver, gallbladder, and bowel before you give the CCK, because you want to make sure that your patient doesn't have cholecystitis or blockage, right?
What would happen if they did and you gave it, it would get really sick or?
Well, if they're obstructed, and they were obstructed with a stone, and, I mean, there's like, worst case scenario, I mean, best case scenario, your patient throws up on you. Worst case scenario, you rupture one of those ducts. So that's why we just don't do that.
I was just curious.
Yeah, that's why we just don't do that, so yeah. Yeah, best case scenario, your patient pukes, worst case scenario, they're gonna go to the OR. Although, you know what, they were going to the OR anyway, right, so it doesn't really matter, but, so yeah. So you got two kinds of biliary dyskinesia, a CDS and an SOS. Your CDS is a chronic acalculous dyskinesia, okay? Acalculous just means it doesn't have any stones in it. Okay? But you could have sludge in the gallbladder, thickening of the gallbladder wall, which makes it sluggish to squeeze, right? Or you can have a sphincter of Oddi dysfunction, which is an SOS. This is a chronic, either a spasmodic reaction or a chronic dysfunction of the Oddi, of the sphincter of Oddi. Okay. If you have a chronic constriction of the sphincter, they can go in and balloon it open like they do angioplasties. They can go in and balloon it open. They can put in a stent sometimes. Or believe it or not, they will put you on cardiac medication, a beta blocker, because beta blockers will stop that spasm from happening. Okay? Okay. So there is a med on the market called Neocolex, which you can give orally, which is supposed to simulate, CCK. But Neocolex is what you're going to give to the patient that you suspect has a stricture of the sphincter of Oddi. But it can be given for either thing. And then you've got Kinetivac, which is Syncoli, which is given IV. Your maximum effect is 2 to 3 minutes post-injection, and it affects the last 8 to 10 minutes after the stop. Okay. So basically, the reason. Once you give your patient your Kinetivac, you're going to go dump your dose, you're going to scan it out, the medical administration record, you're going to do all your things, and then you're just going to go chill in the room with your patient, check on them. You okay? How you feeling? You okay? Typically, by the time that 3 minutes is up from the maximum effect, your patient starts to feel better. If they get sick, if they get nausea, if they get a sweat, you'll spend a lot of time with your gallbladder patients like this next to their bed. Fanning them because they're hot, and the hot flash from the CCK, right? Usually in 3 minutes, they start to feel better. 5 to 10 minutes, they're back to normal the way they came, okay? And this is the reason. You're getting their maximum punch for their buck for the first 2 to 3 minutes, and then by 10 minutes, the effects are gone. So it's like it never happened, right? So typically by 3 minutes, your patients start feeling better. By 10 minutes, they're back to normal. Okay. Typically. So, here's the thing about CCK, without this tidbit. CCK, the patient's reaction, their physical reaction to the Kinetivac is not indicative of the outcome of their study. Okay, so you would think, oh, if my patient got sick, their gallbladder must not be working. That's not always true. So your patient's reaction to the CCK, whether they have no reaction, or they get the sweats, or they get nauseous, or anything like that, is not indicative of how the outcome is going to be. If you work in a place where you have an older surgeon, they're going to ask you, how'd they do when you gave them the CCK? The young guys don't care. They just want the results, because it doesn't They just are forming a different picture in their head for their surgical plans. Either way is wrong, but, now. This says that we are usually responsible for reconstituting CCK. I have found that that is not the case. Okay, so are we able to make CCK? Absolutely. It comes in a vial, and you reconstitute it with distilled water or sterile water, and you shake it up, you let it sit for 5 minutes, you do the weight-based calculations, you draw it up, and you call it a day. Okay, it is completely within your practice. When I started, we made all of our own Kinevac. Most pharmacies and hospitals want control over this because it is a medication, and you will order it in the MAR. They will prep it for you and call you and tell you that it's ready. You should go down to the pharmacy to go pick it up. Okay, so it really just depends on where you're working, if you're making your own or if you're getting it from the pharmacy. Most hospitals, smaller hospitals, you get it from the pharmacy. Okay. So, the difference between reconstituting Kinevac or CCK or Syncalide is that most things that you reconstitute kits with in nuclear medicine is saline. When you're making radiopharmaceutical kits, it's saline. When you're making cold pyrophosphate, it's saline. When you are what they call MQSA, meaning adding volume to drugs, it is saline. However, if you're making CCK, it has to be distilled or sterile water. Has to be distilled or sterile water. You cannot use saline. Okay? Now, you need a computer to be able to acquire these images and to process these images for this CCK. You need at least 20 minutes of pictures post CCK to make a valid ejection fraction calculation. Some places acquire images for 30 minutes, some for an hour. It just depends, but you need 20 minutes at least. To get the full effect, to get a proper ejection fraction. At least 20 minutes worth of pictures. So, when we were talking about how you can do these statically or dynamically, right? This is how you would process a static, right? So you're going to pull up your image right before you give the CCK. You took a picture for 500K right before you gave the CCK. Then you gave the patient a CCK, you sent out to the waiting room for half an hour, and you brought him in and take another picture for 500K. Okay? You got one picture here and one picture here. Okay? So what you're going to do is go into your little computer, and you're going to draw something called an AOI or an ROI. It's either an area of interest or a region of interest around the gallbladder. The way that you calculate this is you are going to take ejection fraction equals your big number minus your little number divided by your big number. Okay? So basically, the gallbladder, the count in the gallbladder when it was full or pre-CCK, okay, minus the count in the gallbladder post-CCK, and divide that by the full amount that you had pre-CCK. And that will give you your ejection fraction. Okay? Now, if you acquire it dynamically, you are going to draw that same AOI or ROI around the gallbladder, and the computer is going to automatically draw it on all 30 pictures, because say you did 30 minutes worth of imaging. So you're gonna have all 30 of your pictures up, and it's gonna be the same. It's gonna take that and extrapolate it and put that same region on every single picture, and it's gonna create you a time activity curve. At this time, it counts for this. At this time, it was this. At this time, it was this. At this time, it was this. And then the computer says, I'm taking the high number minus the low number divided by the high number, and this is your ejection fraction over this period of time. Okay? It will also give you the EP, right? Your EP is the time it took you to go from full to empty. So it may say to you, your GBEF equals 38% by 30 minutes, by 20 minutes, 18 minutes, okay?
Was it EF where it says full minus empty, are both of those fulls the post-CCK full?
So, nope, so actually, the easier way to do it is ejection fraction is pre-CCK minus post-CCK divided by pre-CCK. Because I think that is easier to understand than full, empty, full. Because it tells you which one goes where. And then, of course, times 100, because we like times everything by 100 to make a percentage. So pre minus post divided by pre times 100. That's your gallbladder ejection fraction calculation. Okay. Yeah, pre minus post divided by pre times 100. And luckily your computer will do this all for you because we love a good computer in nuclear medicine. Okay? But what happens if your patient moves? So now you've got all the gallbladder in the region, all the gallbladder in the region, all the gallbladder in the region, and then your patient decides they're going to sneeze. Now your gallbladder's all the way down here and your region's up here. What do you think that does to your graph? Yep. Yep. So that is when you may need to say, I'm going to extract the full, what I think is full, what I think is empty, and then manually do the math yourself. So you can always do that. I recommend to everybody, and I make my techs do it still, and it drives them bonkers, but it saved their bacon the other day. Always, even if you're doing a dynamic HIDA scan, take a pre-CCK picture, and then it's 1 minute. We do a 1 minute pre, and then we let it run for an hour, and then we do a 1 minute post. Right? So we do the regular HIDA. We see everything. We take a 1 minute static. Then we run the CCK, and then we do a 1 minute static at the end. And I make them do that because if your patient is doing this, none of your regions are going to be adequate, and depending on what kind of camera you have, you can't move the region. If you move it, it moves it for all 30 images, or all 60 images. So it just depends. It saves your bacon. I've also had to save my bacon on a gastric emptying study when we lost power. Somebody hit a pole out front. We lost almost the whole study. Well, we did lose the whole study except for the statics. So we were still able to tell him how much he was empty, which was a good thing.
I thought some of the cameras had like automated things where they could detect motion and try to like fix it.
No, girl, no, they don't do that. No. No. For a stress test, they will.
Oh, okay, maybe that's what I'm referring to.
However, guess what? If it moves more than 2 pixels, you have to rescan the patient
Right, I
anyway.
remember saying that, okay.
Right?
That's probably what made me know, because I remember the 2 pixels.
Because now you are, because you're only moving 2 pixels, but if your patient sneezes or coughs, it's way, I mean, you're looking like this much of a drop. You can't fix that. Like, unless you can do it frame by frame. Now, some of the old equipment, you can do whatever you wanted. I could put one region up here, I could put one down here, I could put one up here. It did not give a crap, it will calculate it. Now, in an effort to make everything fail-safe, they've made our lives longer.
So like everything with the old camera's better than for that reason, or?
You could scan the patient under the wrong name, and you just pick it. Oh, I scanned John under Alexis. All right, well, the resting says John and the stress says Alexis. The camera will go, hey, it's 2 different patients. You go, I know, okay. And it just lets you do it. And then you label it appropriately. Now, forget it. It's like an act of Congress to try to move images over and, you know. So in an effort to make it so, I hate to say idiot-proof, but that's really like what it is. Like, they've made it harder because mistakes happen. If you're scanning 30 patients, the probability that one day you're gonna scan the wrong person under the wrong name, it's gonna happen. You know, it's gonna happen. We're human. Okay, this is what we were talking about with the gallbladder curve, okay? So here is your ejection fraction imaging, right? So what this scanner does is, I think this is a Siemens. So what this scanner does is it takes all of these images and compresses it into one picture and makes a composite. That's where it draws its region, right? And then it says, okay, the gallbladder was filling. Now this is the highest point, okay? We gave CCK, I didn't even say when you gave CCK, but I'm assuming we gave CCK at 45 minutes, 50 minutes maybe, right? So then it takes the high to the low, and that's how it does your minimum minus maximum, because here's your max. Your maximum counts are 113,558, and your minimum was 88,551. So that's how it gets that 22% ejection fraction, which it calculates at the bottom. Now,
Sorry, I have a question. So the curve going up is the gallbladder filling up,
correct.
and then down is empty.
Right. So this was acquired dynamically the entire time. So this was a 90-minute dynamic acquisition. So when they started the patient, your counts were 0. So this is your immediate picture. And then they waited until almost 60 minutes, 50, 45, we'll say 50 minutes. They saw everything, then they gave the CCK. So on a normal, if you do it, I shouldn't say normal because it's not normal, but normally what you do, or what at least I've always done in my career, I take the first hour's worth of pictures and I let the patient up to go to the bathroom. You have to go pee, stretch your legs, whatever. So when you put them on, you're gonna start here. You're not gonna have any of this noise back here, because you're gonna start here, and this whole graph study over here. Now I will tell you about this. They gave CCK too early. And I will tell you why they gave CCK too early. The reason that you have this refill here, because that's what this is counts going back into the gallbladder, is because they had too much activity in the common bile duct when they gave CCK, right? So what you want to try to do is get your gallbladder nice and full and your common bile duct empty, which is another reason that the old people get them up to go to the bathroom. Gravity helps you. These patients are laying down for an hour, right? Gravity's your friend, okay? You're still gonna have some patients that refill. There's nothing you do about that. But it's always better to try to get a big fat gallbladder and drain that common bile duct as best as you can, okay? So it doesn't refill. But this is what we say with the time activity curve. So it's always counts are up the left, time is across the bottom, okay? So this is more typical what it will look like, right? So see how you have no noise over here? It's your graph pretty much starts here, right? So that's your image 1, And here is all of your imaging, and it kept your thing, kept your region for each one. Okay, and then did your time activity curve. And see how you don't have a lot of refill? Because you did not have a lot of common bile duct when you gave the Kinemac. So your curve goes down and then it's flat. It's also always important to look and make sure that the number that you get makes sense. So you know that this is over 50%. All you have to do is look how bright this picture is in number 1 and 2, and how there's almost nothing there at the end. So if you got an ejection fraction of 17, something's wrong. Because if your ejection fraction was 17, you really shouldn't be able to tell the difference. It should look all the same intensity in that region of interest all the way down the study. But you can look at it and go, oh yeah, it's definitely more than 50. That's definitely more than half. There's like nothing left. Okay. Normal ejection fraction is 35% around 20 minutes. Right, that's your normal. Anything over 35% is normal. Okay. What's up with this puppy? What do you think? You got liver? Right? So we started it early. We probably injected the patient, started the camera right away. How do I know that?
The first picture is lighter.
First picture is lighter. So if you had to guess, what would you call this patient? We're gonna say this is at 1 hour. So is it normal or is it abnormal? That's the first thing.
Abnormal.
Abnormal. Do you need more pictures or are you done?
Need more pictures for the delay scan.
You need a delay. Why do you need a delay? Because you're missing what?
Gallbladder, gallbladder, or
Missing gallbladder. Okay?
so.
Yep. Now, I will tell you, you're not gonna get, just from experience, you're not gonna get a 4-hour picture on this person. You better bring them down in 2 hours. Because you're almost out of liver activity.
But still no. But
So,
still no
and
gallbladder.
if you bring this picture down, this patient down another hour, you're gonna have nothing and it's gonna be all bowel. And then you're done regardless, whatever happens, you're done, because you can't image anymore. Okay, it won't go backwards.
So what would normal look like? You could visualize all 3.
Yep.
But then, so when we were talking about, you have to visualize all 3 and then give the CCK, is that?
If it's ordered as a CCK, not every scan is gonna be ordered as a CCK. Yeah, it just depends, not every study is.
If that's like, if they're still complaining of pain when they eat, then you can see all 3, so that's like for dyskinesia, basically.
The EF is for
Okay.
dyskinesia. Yeah, they wanna see if it works.
And I'm sorry, what did you say the, injection fraction?
35.
35.
35%, usually by 20 to 30 minutes. Yeah.
So in the previous, images, if, because there's liver and bowel, could you use morphine as a way to see if it'll take in the gallbladder?
It's too far out.
Okay.
I don't think a radiologist would tell you to give morphine to this patient, because you're all the way, so you're out past, the CBD is long, you're way past here. You don't have a lot of ductal activity. So morphine works when you have activity still a lot in the common bile duct, because it'll shoot it back in there. But once it goes all the way to the duodenum, it won't push it that far back up the biliary tree. Okay, plus you don't have, now, if you had probably this much liver, they probably would, because you still have a lot of activity in your intrahepatic ducts, and that'll push it the other way. So it really just depends on the radiologist, and that's one of those calls where you take them the picture and you go, what do you want us to do? What do you want to do with this? Some radiologists will look at this and say, you're almost out of liver, the patient's done. Some will say, I want a 2 hour to confirm. It just depends. So this is kind of when you lean on your radiologist to be like, yo, what do you want me to do with this? Because I always remember, and this is what I tell even my techs when they get aggravated, I said, listen, the bottom line is, their name goes on the report and they have to be able to stand up for it in court. So even if you think what they're asking you to do is completely stupid, it probably is, but the bottom line is, you're not gonna have to justify it in court to somebody. So just do what they want you to do, right? But yeah, at that point, I probably, if this was the 60-minute, I would say they probably would. If you do that. Now, where I work, I've worked there 28 years, I've never given a patient morphine because my doctors don't want to do it. It really depends on the doctor that you're in, where you're working. So here's a good one. So this is a 1-hour picture. So do you think this is a common bile duct obstruction? What do you think is going on in this picture? You're 1 hour out, so this is at the end. It's just liver. So what does that tell you about this patient?
There is an obstruction.
Where? He could have a common bile duct obstruction. He could have an intrahepatobiliary duct obstruction. He probably has a markedly elevated bilirubin and he is just not processing the drug. Big bird, exactly. It's probably a big bird. Probably a very high T-belly. So, if he had gallbladder, right, but nothing else, then he would 100% have a common bile duct obstruction. Like, you know that, because he's got gallbladder, right? But could be a common bile duct obstruction, but we have no gallbladder, so I don't think so. I think he's got hepatocellular dysfunction. But not severe hepatocellular dysfunction, because if he had severe hepatocellular dysfunction, we'd have heart right here. It wouldn't even be, we would still have cardiac activity because it would still be floating around in the blood because it wouldn't pull it into the liver. Also, if you have a baby that's pictured that's look like this is exactly what biliary atresia looks like. Liver and nothing. Nothing, because there's no biliary tree to drain the bile out of the liver. So you got nothing. So what about this one? Normal? Abnormal? A little bit. Normal or abnormal?
Normal for me.
Normal.
Normal for me, yeah.
Yep. Liver, bless. Liver. Common duct. Gallbladder. Bowel. There's so much activity in the gallbladder that it actually started to pixelate. This is an old scanner. The liver has completely metabolized all of the dicefenin, so that's why you have no liver left. It's all been processed, it's all been put into the gallbladder, and now it's starting to squeeze out into the bowel. But there's so much activity in the gallbladder that it's actually pixelating itself, and it's shutting down the pixels because the pixels are overloaded, right? They're oversaturated, so it stops, right?
Are those dynamic images?
Yep. I wish they were labeled with time.
The gallbladder is that little teeny tiny one, like in the second to the bottom row?
So gallbladder starts right here,
Okay.
and then just gets bigger and bigger and bigger and bigger.
Yep.
And see how you see the common bile duct really bright,
Mm-hmm.
and then it goes away, all you see is gallbladder, that's it.
So you can like see the tracer moving throughout this.
Just make it a hole.
So because this was dynamic, was a dynamic study, you could do a cine and hit the play button, and you can watch it. Okay? So, here we go. This is the case history for that lady. Yeah, that one was normal. 20-year-old woman with a 6-month history of abdominal pain, prompt uniform accumulation of the tracer by the liver, normal filling in hepatic ducts, common bile duct, and gallbladder, normal excretion of the tracer in the duodenum. In a normal hepatobiliary study, the gallbladder and bowel will be visualized during the first hour of imaging. Okay. The second picture was biliary atresia. 2-week-old infant with elevated bilirubin and acolic gray stools. Sequential images obtained over 60 minutes after injected demonstrated prompt uptake of radiopharmaceutical by the liver. No evidence of excretion of the radiopharmaceutical into the biliary system or small bowel. Renal clearance into the bladder was noted. Additional imaging obtained at 4 and 24 hours demonstrated no bowel activity. Yeah, there we go. This is the biliary atresia. It's like, wait a minute. So here's your biliary atresia. See the activity, see how pixelated this is starting to get? So this is turned up too high. Remember we were talking about grayscales, right? How many colors of gray you have? This should have been pulled way to the right and turned down. The problem it's not is because the technologist wanted to prove that the baby had bladder activity. This is bladder. Okay. So sometimes you'll get a picture and you will what we call blow it out, like you'll make it really, really dark to be able to prove something else. So this is probably not the only image that went to PACS. The initial image that went to PACS probably had everything else lighter. This was darker to prove that the baby had bladder activity.
So that's liver and bladder that you're looking at.
Yeah,
right?
liver and bladder. And there's cardiac activity all the way down. So you got baby heart. Heart, it's kind of hard to see, but it's a little better, it's a little easier to see on my screen. So this is your anterior dynamic images after morphine administration. And it still doesn't look like it went back into the gallbladder. Because this still looks like duct. But this is a prime example of when you need to do a right lateral and an oblique. Because just looking at these pictures, I can't tell if that's gallbladder or if it's common bile duct. So that's when you do a lateral and you do the oblique to see if it moves around. Because if your patient is tall and thin, so most of the time your gallbladder will sit out like this under the lobe of the liver, but if your patient's tall and thin, it will lay like this, straight up and down right next to the common bile, like right next to the duct. Okay. So I can't tell what that is. Yeah, look at that, right lateral. It was gallbladder. Because here's your bowel, and see how your gallbladder is all the way in the front, all the way out here. Right, so you're good to go. Which is also why you have to label your images. Okay. There we go. this is a biliary leak. So your bile is supposed to flow, right? Intrahepatic ducts, common bile duct. You don't have a gallbladder in this patient, right? Patient doesn't have a gallbladder. So then, what's this, right? So then you go and now it looks like it's leaking into the gallbladder fossa. And that looks like a lateral. That looks like a lateral. So when you have a study that looks like you've got gallbladder and you know the patient doesn't have a gallbladder, that bile sometimes can leak into that gallbladder fossa.
How do you know the patient doesn't have a gallbladder? Because from those images, like, I would think that was a gallbladder. Just
Because you know.
history?
Because you know when the patient comes.
Okay.
First question you ask your patient is,
Yeah, yeah.
do you have your gallbladder out? That's your first question you ask the patient, right? But when the surgeon is looking for a biliary leak, it'll actually say in the comments, rule out leak. So like you'll know.
Okay.
Yeah, you'll know.
Because if I just saw that image on a test, I wouldn't know unless like somebody told me that.
Well, and here's the thing. So you see a study that looks like this, that's when you lean over to the patient and go, are you sure you didn't have your gallbladder out? Like, and then you flip to the chart and start looking. Like, sometimes patients don't remember. Like if they're older and they had their gallbladder out when they were 30 and they're 70, like they might not remember. I don't know, maybe they don't remember, you know? So sometimes you have to kind of, look. But these biliary leak studies will come off, rule out leak. Like you're gonna know when the patient comes down. I guess you got some better. Woo. But you can tell that this is a leak because this does not follow normal bowel activity. Like this doesn't belong here. Like your bowel doesn't loop up like that. It goes down and down and down. This doesn't belong here. So I'll see if I can, when I go to work, I'll see if I can find some actual like movie jobbies. So here's what we were talking about with decreased hepatocellular function, right? So at 5 minutes, you still have heart activity, right? 60 minutes, you have liver still, but you have nothing. 24 hours, you still have liver activity. And kidneys and bladder, right? So kidneys and bladder on HydroScan means that the body has started to break down that amino acid chain, which is the IDA, and now it's being processed by the kidneys. Right? So you still have liver at 24 hours. So this patient has some kind of obstruction. Or they just have hepatocellular dysfunction. Like that's where you have to look at the patient's labs and all that. Like you tell the doctor, you just go, because they go, what are you saying? I'm like, well.
How long does it normally take to clear? Like you said, at 24 hours, you shouldn't be able to see it still.
You should have bowel activity at 24 hours, just bowel, that's it. There should be nothing in the liver, nothing in the gallbladder, nothing in any of the ducts, just bowel activity. Just bowel activity. So biliary, 5 minutes post injection, prompt accumulation of tracer by the liver, and some residual blood flow activity in the heart, 60 minutes. The heart blood flow activity is resolved, the liver demonstrates no significant excretion to the biliary tree, 24 hours still in the biliary tree, no significant small bowel. Oh, patient had tumor. Sonographic image confirms the presence of a gallbladder as a fluid-filled structure based on the liver. Transhepatic cholangiogram demonstrates a round mass-like structure producing obstruction. The contrast passage via the CBD. Follow-up image demonstrates that a catheter was passed beyond this point of obstruction and into the duodenum. So he had what they call a mechanical obstruction by because of a tumor. Normal, abnormal. gallbladder. No gallbladder. Right? So, those are 30 minutes prior to pharmaceutical injection to promote initial emptying of the gallbladder. Static images obtained in the first hour post-injection. Good hepatic uptake, good prompt excretion into the CBD and small bowel. No visit the gallbladder at 1 hour, then they gave them morphine. That's this patient. So, normal study, just took a little extra oomph. Took a little extra oomph. Okay. So, which of the following is not used to image the hepatobiliary tract?
C.
D, all of them are. Colotec, mebrafenin, they're both IDA compounds. All of those are used. Right? Any kind of an IDA compound, Colotec, mebrafenin, they're all IDAs. The gallbladder is visualized in how many minutes post-injection of the radiopharmaceutical? 20-30 minutes. Yep. 20-30 minutes. Visualization of the liver and gallbladder, but non-visualization of the bowel is most likely due to the obstruction of the what?
Colon body.
CBD. What are the cells in the liver?
A and B. G.
B and C.
B. A, B, C. All of the above.
And B. They're reticuloendothelial
Oh,
cells,
okay.
not
Yeah.
endothelial cells. Endothelial cells are in your mouth. Reticuloendothelial are
A and
inside the
B, yeah.
gut. Yes.
Reticular, sorry.
What is the method of localization of hepatobiliary agents? B and C.
B and C, yeah.
B and C. Phagocytosis is sulfur colloid, and we'll get into that later. Right? B and C. Pinocytosis into the hepatocytes, and then active transport to the gallbladder. Normal GBEF is less than 30, more than 30, less than 50.
More than 30.
More than 30. When is CCK administered?
The remote scene. A.
Okay, so what are you looking for? Why are you giving CCK? Right? So if you don't see the gallbladder, why would you give CCK? Gallbladder is not visualized yet. So C, when the gallbladder is at its fullest. Remember I was saying you want to make sure it gets full and try to get out of the ducts, full. The fullest it can be. Okay? Because you wouldn't give it an A because you haven't seen it yet. You've got liver and bowel, you haven't seen it yet. Okay? So if you're trying to see if you get acute versus chronic cholecystitis, you're not going to give CCK, you're going to give
Morphine.
morphine.
Sulfur.
When you first see the gallbladder, you have no bowel, so you can't give CCK because you don't know if there's an obstruction, right? And if the gallbladder is already contracting, you don't need the CCK, right? So it's C. When the gallbladder is at its fullest.
So you give CCK, you're trying to find an obstruction.
You give CCK to determine the
Function.
ejection fraction of the, right? Okay. Or you give it prior if you are looking for, if the patient hasn't eaten in a long time. Which of the following will cause the gallbladder to contract?
A.
A
And C.
A and B and C. A and B and C. These two things are post, right? Morphine is pre, right? You give morphine pre, Or you give morphine to try to rule out acute versus chronic cholecystitis, right? To release the sphincter and get it to go back up there. In a normal hepatobiliary scan, which of the following structures will not be visualized?
Spleen.
Spleen, correct. Okay. A patient, in preparation for a HIDA scan, patients are fasting. Why do we tell them to fast? C, we don't want them stimulating the gallbladder and get a false positive or a false negative. Okay. Would a patient with a HIDA scan ever have radioactive emesis? Emesis is vomit.
When you give.
No.
Can you give
Patient would never have radioactive emesis from a HIDA scan because the medication that you give them is only taken up by the hepatocytes, and you don't have hepatocytes inside your stomach, which is where vomit comes from, right? So they would not. However, if you do a gastric emptying study, your patient always has radioactive vomit because they're throwing up the eggs that you made them eat. Okay? Which of the following agents would be used to perform a GEEF?
All of them.
What'd you say, all of them?
Cervical.
Sulfur-colloid is a liver structural agent, right? Remember we talked about the Kupffer cells and the phagocytosis? That is sulfur-colloid. So you could use A
Or B.
or C.
Yes.
Cannot use B. Okay? Cannot use B.
That's true.
How do we give IDA agents? IV. 2 hours after administration in a normal patient, so you're at the 2-hour mark, where should most of that Colotex be? C. Most of that Colotex should be in the bowel if you have a normal patient.